SAPHO syndrome is the topic of discussion for this video. Hello dear students, myself Dr. Maddineni Srinivas, your dermatologist from Bharat. So let us begin the discussion. This was a 5 marks question asked in the DME examination, the paper 2. So some intro about the SAPHO syndrome. Basically, this is a rare disease which is chronic and there is going to be a relapsing history which is very important given by the patients. It is an inflammatory condition affecting not just the skin but also the musculoskeletal system. And what is the full form of the SAPHO? It stands for Synovitis, Acne, Pustulosis, Hyperostosis and Osteitis. So you are going to see not only the inflammation of the skin in the form of the acne variants, but also we can see the inflammation of the synovial membrane, and there can also be palmoplantar pustulosis and pathological osteogenic bone hypertrophy, and there will be inflammation of the bone. So let us look at the evolution of this condition. How was this SAPHO syndrome diagnosed initially? Earlier stages, there were reports of cutaneous pustules and also acne, which were present associated with osteomyelitis and arthritis in 1960s, but still the name SAPHO syndrome was not coined. In 1987, French dermatologist Chamot et al. Coined the acronym SAPHO to consolidate these seemingly disparate, that is unrelated cutaneous and osteoarticular symptoms into a unified clinical entity. Right? So coming to the spectrum, the modern classification frames the SAPHO along two major clinical spectrums: pustulo-psoriatic hyperostotic spondyloarthritis, placing it within the seronegative spondyloarthritis, that is rheumatoid factor negative family. The second one is CRMO, chronic recurrent multifocal osteomyelitis, and this is mainly in the pediatric equivalent of the autoinflammatory bone disease category. Right? So if you look at the epidemiology, the age of onset, it primarily targets the children, adolescents and young to middle aged adults. It is extremely rare to be seen in the patients over 60 years of the age. Coming to the gender, there is slight female preponderance under the age of 30 years, whereas older adults, it's going to have equal gender distribution. There is no difference. Prevalence, it's very interesting that the temporal dissociation, which is very commonly seen in SAPHO syndrome, that is the skin eruptions and the musculoskeletal symptoms may not be present at the same time. So because of this SAPHO syndrome is very under recognized and also under diagnosed syndrome in the population. So prevalence is very low on paper, but it may be actually very high because of this temporal dissociation. Now coming to the etiopathogenesis, the exact pathogenesis remains unclear, but it is widely considered to be multifocal autoinflammatory disease, which is going to have a interplay between the genetics, some infections and some component in the immunity. So this is the interplay between these three conditions, mainly these three, not conditions exactly, these three categories of triggers, right? So in the genetic predisposition, you can remember there can be association in the patients with HLA-B27 and also PSTPIP1 mutations. In the infections, remember this organism is important, which is associated with acne. And the immune system, there is going to be hyperactivity of the innate immune system, basically the interleukin 1, interleukin 23, T helper 17 pathway. Apart from this also there are many others, we are going to see that, but here this is just a trailer. Okay, so basically because of the interplay between these three, what happens is in the skin there is going to be this neutrophilic infiltration which will be forming pus, but this pus is sterile because there are no organisms. So pustular nodule formation will be there, and in the bone what will happen, there will be osteoclastogenesis via the rankle because of which there is going to be neutrophilic osteitis and periosteal hyperostosis. So ultimately this will lead to the clinical manifestations of the SAPHO syndrome. So briefly about each of these components. So infectious component, the Cutibacterium acnes, which was earlier called as Propionibacterium acnes. It is a slow growing anaerobic rod, common skin commensal, as you all know. We have already discussed this in the microflora, skin flora and different sites video. Okay, if you have not yet watched it, watch it. Very important topic, question for 10 marks. Right, now coming back to this Cutibacterium acnes, is frequently cultured from the bone biopsy specimens of the Osteitis lesions of the SAPHO patients. So that's why it is hypothesized that this bacterium acts as a low-grade pathogen, initiating a chronic osteogenic inflammatory response in immunologically vulnerable host. So who are these immunologically vulnerable hosts in whom this interleukin 117 axis is going to be activated? So dysregulated activation of the innate immune system leads ultimately to the production of the pro-inflammatory cytokines, specifically interleukin 1 beta, tumor necrosis factor alpha, interleukin 23, 17. This is going to drive the localized recruitment of the activated neutrophils to both skin and also in the bones. If you remember, that is the reason why in the bone also we have seen the neutrophilic infiltration. So finally, the genetic component. HLA-B27 association is lower than the classical spondyloarthropathies comparatively, but genetic overlap has been documented with PSTPIP1 gene mutations linking SAPHO to even PAPA syndrome, that is pyogenic arthritis, pyoderma gangrenosum and acne, and also as an auto-inflammatory syndrome spectrum. So what will be the clinical manifestation? You know the full form of the acronym already. So with that we can just build up the clinical manifestations. And if you remember, we have already seen etiopathogenesis. This is going to be this neutrophilic infiltration. So this the hallmark of this SAPHO syndrome is a combination of the specific neutrophilic dermatosis with aseptic hyperostotic bone and joint inflammation. Remember this point? It is aseptic. There will not be any organism which is going to cause infection literally in these patients. Okay, so coming to the cutaneous manifestations, dermatological involvement is seen in majority of the patients and typically consists of two distinct patterns of sterile neutrophilic pustulosis. So what are those two patterns? Mainly it is going to be in the form of the palmoplantar pustulosis, right, and also in the form of the pustular psoriasis, and also in the form of the severe acne variants, right. So basically you can remember it as acne and also pustular lesions in the skin. So coming to the precisely PPP, palmoplantar pustulosis, crops of sterile deep-seated pustules can be seen on erythematous base, localizing especially to the palms and soles. Obviously it is palmoplantar pustulosis, right. And this is the most common skin manifestation in the adult SAPHO cohorts. Almost in 60% of the patients, this is the cutaneous feature which can be seen. In the acne variants, you can remember severe acne variants like Acne Conglobata, Acne Fulminans, and Hidradenitis suppurativa will be the important manifestations, right? And these often correlate with the flares of the skeletal osteitis, and it's more common in the young male individuals. Pustular psoriasis is generalized or localized erythematous plaques studded with sheets of sterile pustules. And this pustular psoriasis in the SAPHO patients, it illustrates the close pathogenic overlap between SAPHO and the psoriatic arthritis spectrum. Now here comes interesting point, the temporal variation. Cutaneous and osteoarticular lesions do not always occur simultaneously. So this is what we have discussed in the initial part of the discussion, that the skin lesions may not be seen simultaneously with the musculoskeletal involvement. So that is the reason why the prevalence was very low. And skin lesions can precede bone lesions by several years, or they may occur concurrently at the same time, or they may develop long after the musculoskeletal symptoms have stabilized. So what will be the osteoarticular manifestation? The skeletal lesions of SAPHO are characterized by aseptic osteitis, hyperostosis and synovitis. And this is going to exhibit specific sites depending upon the patient's age. So if you look at the adult, the hallmark involvement is anterior chest wall, which is seen in 65 to 90% of the adult patients with SAPHO syndrome. Very interesting. And yes, the involvement is mainly in the form of sternoclavicular joint involvement, anterior chest wall. Okay. Now here we have 30% of the cases where the spine involvement in the form of spondyloarthropathy is very important. Finally, we have the pediatric age group in whom the long bones and the mandible involvement is very classical. Okay, and it is going to present especially as chronic recurrent multifocal osteomyelitis and also mandibular osteitis. So what are the investigations which can be done in the SAPHO syndrome patients? Remember, this is a condition which requires multi-level approach, that is multi-pronged approach both in investigations and also in the treatment. So obviously in the investigations you can see these are all investigations routinely done from orthopedics to identify the osteoarticular lesions. So technetium 99 bone scintigraphy. We can also remember the conventional X-ray, CT scan and also MRI. So these are going to help to identify the and diagnose the osteoarticular lesions. Coming to the diagnosis and the criteria, that is Kahn's modified criteria, which helps to establish a diagnosis of SAPHO syndrome. So a patient, if you think is having SAPHO syndrome, must present with at least one of the following 3 modified criteria. Remember, the infectious osteomyelitis and the bone malignancy, both of these first should be excluded. Then only you can think of the SAPHO syndrome with at least one of the following 3 modified criteria. So what are those 3? The osteoarticular joint lesions associated with severe acne, right? And also osteoarticular joint lesions associated with palmoplantar pustulosis or pustular psoriasis. Hyperostosis or aseptic osteitis of the spine, anterior chest wall or the long bones, as we have seen previously, right? So anterior chest wall involvement is hallmark for adults. Long bones and mandibles are characteristically seen, involvement is seen in pediatric age group. And this could be with or without the cutaneous lesions. Okay. Coming to the differential, so these are again we can say the orthopedics category area. So the infectious osteomyelitis, Paget's disease of the bone, ankylosing spondylitis. So these are very close differentials. So we need to rule out these, especially the infectious osteomyelitis and the bone malignancy, after which only you can diagnose a patient of SAPHO syndrome. So once it is diagnosed, remember there is no universally standardized guidelines. So treatment is going to be basically according to the patient's symptoms, whether they are having mainly cutaneous features or whether they are having the bone involvement mainly. So it will depend upon that, and it's going to be a multi-subject, that is multiple subjects, orthopedics, dermatology, all of them should be involved, radiologist. And the treatment ultimately it's going to be in the form of anti-inflammatory, antimicrobial or osteoclast modulating drugs. Because osteoclastogenesis is happening, so we are also going to use those medications as well. So obviously the first line medications to treat the symptoms is going to be NSAIDs, indomethacin, naproxen, as anti-inflammatory medications. And it is a first choice to manage a joint pain and reduce the synovitis stiffness. So targeted antibiotics, we have seen that Cutibacterium acnes is having an important role. So that's why doxycycline, azithromycin, which are going to basically target the organism, can be used. And bone targeting agents, so intravenous pamidronate zoledronic acid. So these can also be used because they are potent inhibitors of the bone turnover and highly effective for controlling refractory bone pain, and also importantly to halt the hyperostosis which is occurring in these individuals. Conventional disease modifying anti-rheumatoid drugs, methotrexate, sulfasalazine can also be used when there is concomitant active peripheral arthritis, psoriasis, or palmoplantar pustulosis. Biological therapies. The anti-TNF alpha agents infliximab, adalimumab, etanercept, and also interleukin 17, interleukin 1 inhibitors, secukinumab, anakinra. These medications are reserved for severe refractory cases. Anti-TNF agents have dual efficacy for bone osteitis and severe acne pustulosis. But remember, there is one problem, paradoxical problem with this. We are going to discuss that in the cutaneous management. But before that, just remember this step ladder management of the SAPHO syndrome patients for their bones involvement. NSAIDs for bone pain and joint stiffness. If there is inadequate response, we can think of oral doxycycline azithromycin for the Cutibacterium acnes. And if there is still persistent active osteitis, bisphosphonates, that is palmitoronate, zoledronic acid, can be used for bone pain. If there is severe skin joint involvement, think of DMARDs, methotrexate, sulfasalazine, even cyclosporin can be thought of. And if the disease is very refractory, then biological therapies like tumor necrosis factor alpha inhibitors, interleukin 17 inhibitors, interleukin 1 blockade can also be thought of. Right. Specifically, the SAPHO syndrome skin involvement, cutaneous manifestations, how they can be treated topically with high potency topical corticosteroids, which are going to be the first line for localized palmoplantar pustulosis. Systemic retinoids like isotretinoin, acetretin can be used, but the problem is that isotretinoin can cause flaring of the SAPHO syndrome. So keep this in mind. And acetretin, it is indicated in managing the progressive cutaneous and the arthritis symptoms. I hope you remember in the psoriasis patients, acetretin can be used in pustular psoriasis as a drug of choice. Right? Systemic steroids, they are going to cause symptomatic improvement of both skin and also bone disease, but the problem is long-term use is inadvisable. So keep this in your mind. Next, we have the biologics, tumor necrosis factor alpha. So I have told you that there is a problem with these medications. So there is a paradoxical risk of exacerbation of the skin disease. So you must keep this in your mind. Okay. So interleukin 23, 17 axis, secukinumab, ustekinumab. So these are going to specifically target, and the efficacy is there 40 to 60% for both skin and bone disease. Biologicals, anakinra, interleukin 1 blocker. It is extremely limited data suggestive that this anakinra is going to control the skin disease in SAPHO patients. So it is usually not routinely used. Small molecules, the JAK inhibitors and also apremilast. JAK inhibitors can be used for both skin and bone disease. Apremilast, it is orally available phosphodiesterase 4 inhibitor, shown to be successful in some small case reports in SAPHO syndrome patients. Okay. So that's it about the SAPHO syndrome, dear students. I hope this video was helpful. If so, please do that like button. Also do hype this video, and also do watch the other videos in this playlist where we have covered the other theory questions from dermatology subject. So if you are not yet subscribed to my channel, please do subscribe, and also leave thank you in the comments if you like this video a lot. Thank you so much. We'll meet again in the next video soon. Bye bye.